We're going to move on to the third speaker, our young physician scientist, Dr. Jana Hashash, who's an assistant professor at the Faculty of Medicine, American University of Beirut, and also has a affiliation with the University of Pittsburgh, where she did her study. She's a gastroenterologist who's interested in clinical translation research and who has a master's degree in clinical science and clinical research. And the question I had for Jana is, Jana, you're the young, bright physician scientist. You've went the traditional approach, hypothesis-driven, with a target and targeted approach, and now we have this big data and data mining. What are your challenges? So welcome, Jana, to address big data, big answers, but how?
Thank you so much for the organizing committee for inviting me, and for Dr. Hashash for being a wonderful mentor during this. So this is the first time I don't talk about my research, but instead I talk about something else. Big data, big answers, but how? So I'm going to give you a little brief briefing about me. I'm a physician scientist. I obtained my medical degree a little over 10 years ago and moved to the United States, where I did my residency in internal medicine, gastroenterology, and then a subspecialty in IBD, or inflammatory bowel disease. And then I started to become more and more interested in translational research and clinical research. So I obtained a master's degree in clinical research in order to have more sound research ideas, methods, etc. So what I actually work on is early detection of dysplasia, which is a precancerous condition in the colon, in our inflammatory bowel disease patients, to prevent cancer from occurring. I also want to identify who the high-risk patients are before they develop dysplasia. So who's going to go ahead and develop dysplasia? I also study proteins, particularly MUC1, to identify new biomarkers of disease recurrence, disease progression, specifically in Crohn's disease and a post-operative setting, and also as a therapeutic target. So there's a MUC1 vaccine, and I've been working on getting funding for a clinical trial for vaccination post-operative Crohn's disease. And I also work on study predictors of disease progression and disease complications. So as clinician scientists, all of us have more or less the same goals. We want to improve prevention, diagnostics, management therapeutics, and prognostics. So for prevention, we want to identify patients at risk for a certain condition to prevent the disease from occurring. When we talk about diagnostics, we want to have early diagnosis of a condition to prevent disease progression, prevent dealing with the complications of the disease. And for management, we want to improve identifying which patient's going to improve to which drug, and so we can give targeted therapy and save the patient time and toxicity from receiving drugs that don't work for them. We also want to be able to identify who's going to have a more severe outcome, who's going to require more aggressive therapy, and target these patients. So most complex disorders, unfortunately these days, are without a cure. So the question is why? And that's most likely because each person is fundamentally different from the average of the population. So we need to abandon the one-size-fits-all model and move towards precision medicine, or what we also call personalized medicine. So what does that mean? That means we need to pick the best treatment for the right patient at the right time. So we need to understand when we should treat the patient, what medication to give them, and although you may have twins, one can require treatment right now, the other can wait a couple of months. And we want to give optimal treatment rather than treating by trial and error. And we see that, although in oncology we have a lot of improvements and targeted therapy, but we still face the problem where patients go through first line. When they fail it, they go through second line. If they make it, they go through third line. So maybe we need to start with a third line to a patient instead of a first line and move things forward. So just to reiterate, we have a variability in populations. No one is exactly the same as everybody else. And that's why our job is to try to identify who's going to have a positive treatment outcome and who's going to fail the treatment we give them at the expense of minimizing toxicity. Knowing that, we can alter what drug to give our patients and what dose to give our patients. So this is what precision medicine or personalized medicine is trying to help us with. This is just a schematic comparing traditional approach for medicine and what precision or personal medicine does. And if you look on the your left side, in traditional medicine, we basically have everybody lumped together. We wait until they develop a symptom or a sign, get diagnosed with a disease, and then you treat them with the blue medication, which everybody gets. And if you see here, this is the one-size-fits-all model. Some people benefit, some people have no effect, but they actually lost time and had maybe side effects from the drugs, and then other people really developed an adverse outcome. In comparison, if you look at the precision medicine side, then you classify these people by risk. You know who has a high risk to develop a condition, and you start surveying them before they develop the disease. And you may even treat them before they develop the disease, and it's a happy ending for everybody. Everybody benefits at the end of the day. So now we know that precision medicine means we should target individuals rather than populations. And as physician scientists, how do we build models to improve this? So we get our answers. Gold standard is randomized control trials, where we come up with a question, and our question usually is a PICO question or a PICO question, where you have a patient population in question, an intervention arm, a comparator arm, and then an outcome that you're going to test for. But these are extremely tedious, as you've heard from our previous speakers. They take a long time, require funding, a lot of money, and you may reach a positive outcome or not. So we've used databases to get some answers, using clinical, blood, tissue, and genetic databases. And from accumulating data here and there, we've built prediction models. But now we're faced by an explosion of big data, and now we need to start incorporating new stuff with what the traditional classical way of doing stuff. So I know everybody has heard about big data and what big data is. So what is big data to us? Big data combines various types of massive data described by 4 V's. Some people say 3, but we're going to go by 4 V's. Volume, velocity, variety, and veracity. So what does each one mean? Volume is just a huge amount, massive amounts of data, just beyond perception. Velocity, you're rapidly accumulating data. Just every second, we're accumulating more and more data. Variety, because there's just a heterogeneous information being captured. Some are relevant, some are not very relevant at this point, but may become relevant later on. And veracity, which means that it's accurately reflective of the individual that we're obtaining data about. And examples of where big data come from, you've heard a lot, but for the medical field, we care about electronic health records primarily, because now in AUB we're moving towards EPIC. EPIC is basically, it gathers all sorts of information about people, and this is just accessible. It's a humongous database, or a big database. We can have large medical repositories and databases, machine real-time data. You've heard Dr. Hashash mention how smartphones are going to capture heart rate, blood pressure, blood sugar, sleep patterns, everything. Everyone's going to know everything about the people. And you also have the social media services. So I'm a gastroenterologist. I'll bring you back to GI. So how would we use big data? And this is obtained from a recently published article in Gastroenterology. So we have to come up with a question, a clinical question of an unmet need, whether this has to do with diagnostics or therapeutics. And there's a ton of questions that we still don't have answers for. For example, in dysmotility. Dysmotility is a problem with just moving things in the esophagus or anywhere in the GI tract down the right direction. So at this day, time and age, it's kind of ridiculous for me to tell my patient there's nothing for me to give you or offer you for dysmotility other than sit up straight for a few hours and give gravity time to push the food down. So we need an answer for this. Another example is inflammatory bowel disease. We have 5, 6 different biologics to use. I don't know which one to pick over the other based on this specific person I'm seeing. We do have signals, but we need more solid signals. So we come up with a question that we need an answer for, and then we turn to our big data and access this highly rich big data and collect, integrate, and analyze. Now, the analysis comes up, and we need translational bioinformatics to give me an answer that I can clinically understand. Gives me an answer, what diagnostic tests to do in order to guide me, what kind of therapeutic option do I have, etc. So what are the advantages of big data other than shorter discovery time, lower overall cost, and a higher precision and per target success rate? It also supplements and complements what we get from clinical trials. Big data gives us a global perspective with attention to details. It just doesn't give you a big answer, yes or no. It also gives you valuable details that you otherwise wouldn't be able to capture in a randomized controlled trial. It allows us to detect complex information that otherwise would not be possible. So back to me. This all sounds fantastic. Big data complements randomized controlled trials or the classical trials. We're getting answers faster. We're saving money, especially right now. People don't give us as much money as we ask for with funding, etc. We're able to advance personalized medicine to optimize health. I'm helping my patients. I can almost answer any questions, and we're closer to a cure. And you can see this is very obvious from the, this is a PubMed search of literature that's published on precision medicine, data science, personalized medicine, machine learning. And you can see this just explosion of an exploratory increase in the number of publications per year. But back to me, how do I do this? How do I get into working with big data and publishing? Other than coming up with a question, really I can't manage and navigate these massive data sets, although I tried to help myself by getting a master's degree in clinical research. How do I analyze complex, large, heterogeneous data sets? How do I even make sense of the output? I don't know how to interpret what's significant and what is not, and how do I put all the results together? What kind of training do I need? Do I need to go and do another master's degree in data science? I don't know, so I tried to ask the internet, and actually it proposed machine learning and data analytics, and luckily, this is our next speaker who's going to teach us how to help ourselves. In coming close to conclusion, this requires a multidisciplinary approach. Other than having clinicians, scientists, and physician scientists who understand medicine and pathways of disease and know what the unmet need of medicine is, we need computer engineers and bioinformatic experts who understand machine learning and artificial intelligence. We need public health experts to help us develop models to prevent disease and optimize health. And we also need the business specialists and stakeholders to support our ideas and help us tackle financial challenges. Now I leave you with this question: how about the future physician scientists? People who are in medical school right now who are very interested in becoming physician scientists down the line. We have at least one of them in the audience. With the explosion of this technology and medical advances, should we incorporate big data training and bioinformatics in the curriculums of our medical schools? We really need the new generation to be fluent in the big data language to translate these data outputs into novel biomarkers and drugs to improve patient outcomes, which is actually, at heart, this is why we do medicine. So thank you very much for your attention. And I hope
So I want to thank Jana for doing an amazing job. I think this is one of the most challenging things. She could have talked about her research. She had to really brainstorm about where we are today.